all very much for joining the call. I have a lot of people on the phone here. We're always happy to have these great audiences for our Wednesday webinars. So this is Anne Leo speaking. I'm the Project Director at CHAMPS, and this month I'm hosting the webinar. And the subject of the webinar this month is Changing Minds and Moving On, Overcoming Resistance to the 10 Steps. And I think that any of us who's ever worked in baby-friendly breastfeeding, hospital change has struggled with this issue of how to change minds and how to win people over and how to move ahead with new energy. Before we get into the meat of the presentation, I will just give you some updates from CHAMPS. We now have 20 hospitals enrolled in the 3 states that we have been working in, and a little bit on southern Tennessee. So I was actually out there last 2 weeks in all the states visiting hospitals and at conferences and met many of you. So that was great. And Kim Bog was out there too with me in some of the places, and one of my other assistants came out from Boston Medical. So we had a presence in the South last week. Just to update on the work that Kim's been doing particularly, she's trained 33 community transformers out there right now in the different states, and we're working towards getting them linked in with the hospitals and with the trainings. They have, between them, they start at 5 breastfeeding clubs in the community and participated in a lot of fairs and conferences. My screen's frozen. Okay, this is one of the trainings that Kim did in Delta area, I believe. And this is just a really nice flyer that one of the community transformers has put up in her area. So they're really getting to work in the communities. And this is another of their recent trainings. In terms of some of the things that CHAMPS is offering in the areas that you are, we have 2 5-hour hands-on train the trainer courses coming up. These courses will do 2 things. They will if anyone attends this course, they will go away from this course being able to teach the 5-hour component of what is required for Baby Friendly USA by staff. And you can ask us more detailed questions about that if you need to through the office. But there's basically a 5-hour component which meets certain competencies with hands-on things like hand expression and positioning. Anyone who joins this course will be able to go back to their institution and teach that skill. And at the same time, excuse me, could you mute your lines? There's a lot of interference. Thank you. At the same time, if you attend this course, you will actually yourself be, you will have gotten the 4 of the 5 hours as required. We recommend that the 5th hour, at least one of the hours is spent actually with patients shadowing lactation. But it will be covered. And this course is coming to Memphis on May 19th. And Jackson, Mississippi, May 21st, and the information will be there on the CHAMPS website soon. It's only for clinicians who are in hospitals that are already enrolled with CHAMPS because we do have limited space. And the people who will be running and training that course are Emily Taylor and Kim Bog. Just to give some shout out to the hospitals we have enrolled, we've got these 7 in Mississippi are confirmed, and we have 3 more who are in the process of completing the application and the paperwork. We were at La Leche League with one of the transformers last week, and we really had a great time, and so many hospitals came. It was really nice to see so many of you there. Thank you all. And this is the group that attended the CHAMPS session. So we really had a big turnout there, and this was one of 2 breakouts we did, so we had a lot of people come to our breakouts. So thank you all for those of you in Mississippi who came. It was very nice to meet you all. And the week before that, Kim and I were in Baton Rouge with Alida Williams, who's the head of the breastfeeding WIC training program there. And these are the hospitals that we now have enrolled in Greater New Orleans. West Jefferson is our most recent, so thank you, West Jefferson, for coming on board. And we will be offering a training for the 15-hour course in the New Orleans hospitals in West Jefferson in October, and the details of that will be coming up. We were also in Texas last week, and we visited with all of the hospitals in Texas and spent time there. And these are the 4 Texas hospitals that we have enrolled so far. Texas was one of our, we started enrollment there later than in the other 2 states. And then we have our hospitals in South Tennessee, which serve northern Mississippi. So welcome to all our hospitals and to all of those who are thinking of coming quick before we fill up. And as I say, these are some of the dates which we mentioned already. So moving on to the webinar and the changing minds and the subject that this is. So ideally we would just go out there and wave a magic wand in our hospital, and the people that we have problems with will all just change their minds. I mean, that's what we would kind of wish we could do in an ideal world, and unfortunately that doesn't happen. And what really happens, well, first of all, let's think about who these people are whose minds that we want to change. There's administrators, because they need to put their money in there and their time and support for the infrastructure. There are certainly the physicians who in many cases, and this is just speaking from personal experience, have been fairly big barriers to baby-friendly. There's nursing staff. Again, based in my own experience, nursing is usually running this initiative. In most places that we work with, nursing is behind it. The administration of nursing is behind it, but sometimes you certainly have staff members who've maybe always done it one way and, really don't want to change. And so you do have resistance from your rank and file nursing, although I have to say that most of the time nursing is the people that are generating the enthusiasm for this. And then you have patients and families who are not necessarily familiar with the new way that you've done things, and that you don't have a nursery anymore, and they don't know why they can't send the baby to the nursery. They think it's because you can't afford to staff the nursery. They don't realize, unless we educate them really well, that this is a change for the better in patient care. So they also need to be taught and explained things to. In fact, anyone who doesn't agree with us, and that's really a lot of people. So we have a lot of work to do in terms of changing people's minds. So maybe we need to think a little bit about that. So why don't they agree with us? I mean, I love to say this. I always love to say I'm right. We all love to say we're right, but I particularly like it in the framework of breastfeeding because, by whatever standard you measure it, whether you look at it from an evolutionary perspective, a religious perspective, a historical perspective, breastfeeding is the way to feed a baby. We're all mammals. So the bottom line is we're not making an error here. I mean, the best way to feed a baby, whether you're basic on the scientific evidence or what the Quran says or what what Jesus did, the basic way to feed a baby is breastfeeding. So we are right at the bottom line. So that should sort of lend us fire because we know that our perspective is right. So the problem is that, breastfeeding is definitely an emotional subject, and everybody has had a part in this, and everyone either was or wasn't breastfed, everybody. You can't be one or the other. And then everyone who's a mother, and, we're talking now clinicians too, either did or did not breastfeed, or if they're married to a woman and they have a child or, if there's a child was born, then somebody somewhere did or didn't breastfeed it. So even the male clinicians are also thinking from the perspective of what happened in their own families. And then, there's this kind of weird thing with, especially, we've had giggling residents in many of our lectures when you mentioned the word nipple, and there is certainly a level of embarrassment, and that may not be restricted to older clinicians. Some of the younger clinicians can be very embarrassed and think this, they're trying to make jokes about this because of the sexualization of the breast. So there are many different things that can be in the way, and then sometimes, some of us are just hard-nosed advocates and we push too hard and we get fed up because we meet this resistance and we just don't have the patience to deal with it all, and sometimes we feel like the lone voice and it's a constant uphill battle. So sometimes it can come back to us that we're pushing too hard, we're not taking some of these other considerations into the picture, and we really have to think about the approach. So unfortunately there isn't a magic dot. It's going to take a lot of work, but I always tell people that I would not be doing this 15, 20 years on from having started it, and nor would all the other experts who I'm working with in CHAMPS, who've all been in this for a long time, if we thought it wasn't going to work. And we have gone through situations where we've seen complete transformations in clinicians, in situations, in hospitals, in settings, in atmosphere. So it will work. We know that. That's why we keep doing it. So those of you who are sort of starting out and struggling in the trenches, one of the questions is, well, where do you start? And one of the things that I recommend, unless there's something very unusual at your hospital, where sometimes if something happens specifically that is not a good plan for skin to skin, but in general, I recommend that when we start this change process, we look at skin to skin as one of the places to start. Skin to skin after a normal vaginal delivery is a fairly straightforward thing to do. We're not talking that the baby then has to room in or anything else, just skin to skin. And you will see this particular picture actually is a post-cesarean skin-to-skin, which is like the next level up and also a great thing to do. But if you start doing skin-to-skin with your patients, as long as you're training your nurses to watch the baby on the mom instead of watching on the warmer and keeping it safe, this is going to be something that makes everyone happy. The moms are happy, the babies are happy. People see this, your clinicians witness this, and it will change their minds over time. And again, there's a way to do this without irritating people from the get-go. But if you do it carefully and you implement it well in a thought-out manner, skin-to-skin is one of the ways that you can really start to change the culture, and because you're also getting at people's emotions. I mean, if you talk to moms afterwards and they've been prepared and they knew what skin-to-skin was before it was done to them, you will get big glowing smiles when you ask moms about their skin-to-skin experience. So it's certainly something that, you know, is going to have a happy atmosphere. And I just love this picture. This is one of the very small rural hospitals that I have worked with. And as you can see, the operating room is very small, and there's always this thing about operating rooms are too small. Well, this one wasn't too small, but it was tiny. And you can just see, even behind the masks, that everyone there, including the doctor on the left, is just got huge smiles, because you can just see from their eyes, and everyone's so happy. And I think this was one of the first times I did skin-to-skin in the OR at this particular hospital. So, you know, I would invest some time, thought, and commitment to maybe starting off with skin-to-skin, even if you just only do it for vaginal and not for cesarean birth to begin with. And then, you know, when we're thinking a little bit more about why people really don't agree and why they resist things, you know, let's take a sort of a real but theoretical example that we're not going to name the hospital, but once upon a time in a hospital that was very long way from where you all are. Surprise, surprise, the pediatricians refused to examine newborns in the mother's rooms. And this is just one particular example. There are other things that come up, but in this particular case, they weren't doing it. And when we asked them why, they said it was too dark. And then they added this rather odd comment about if we had portable lights and we left them in the room, someone might knock them over and get hurt, which is kind of, you know, I always say don't tell the tax man too much. And when they said that, this kind of raised a flag with me, like, why are they even going there with portable lights? This is a really odd thing to do. So anyway, hold that thought. They also said they also was, the situation in this hospital was it was very small. They only had 2 to 3 births a week. At the time that we did the mock assessment, when pretty much everything was in place except for this pediatric exam in the room, there was only one baby on the entire unit. It was a small hospital. So, you know, many of these places say, oh, we have to take the babies back to the nursery because it saves us time. Well, in this case, it was not an issue of the time because it took longer to get the baby to the nursery for the exam and bring it back than it would have done to do the exam in the mother's rooms. And everything else was going very gung-ho. They were doing cesareans, skin-to-skin, they were doing everything else. It was only this one thing with the pediatricians. So we did manage to sort of nail these pediatricians, and you know, by the time I got to number 3 and that person told me, oh, the lights are too low, I said, well, let's have a look at how the lights on the postpartum unit, where you examine the babies this week, compare with the pediatric outpatient unit, because that's where I was talking to them. And, you know, at 3 days, they come back there. And the bottom line was that the lighting was actually exactly the same in the place that they examined the babies 3 days later than it was as it was in the postpartum. So it really was not the lights. The lighting on postpartum was the same as in outpatient pediatric. And oh my goodness, we walked into a room and the hospital had actually invested in portable lights, which is why they made that funny comment about if we had portable lights, but they weren't using them. So the bottom line was that lighting was not the problem. And, you know, I can predict that if you start to go back to your hospitals and say, let's do the exams in the rooms, one of the things you will hear is that we can't because of the lighting. And it's not really usually the problem. So what was the real problem? So I started to say to the doctor, so what else is going on here? And you know, they were very open with me, actually. And they said, well, it takes a long time to change. And we said, okay, that's true, you know, but your OBs are doing change, so what's your problem? And then I think this was the crux of the matter. The doctor said, it's only a 10-minute exam. How can that matter? I'm not going to interrupt up this breastfeeding career by one 10-minute exam in the nursery. And, you know, I was really glad we had a conversation because I think that doctor was correct, that one 10-minute exam in the nursery was not going to spoil mom's breastfeeding forever. And now we were actually able to discuss it because that was really what the doctor believed, and I think that what the doctor said was right. But as I explained to this doctor, I actually said, yes, I agree with you, you're right. 1 10-minute exam in the nursery, it's not going to make the difference. But, you're the physician. So if the nurse sees you do that, the nurse will then do her exam, her heel sticks and all the blood work will all be done in the nursery. And then, the nursing assistant who does all the baths is not going to say, oh, well, I'm going to do it in the room if the doctor's doing it. And then the hearing screen person is going to do it. So, it's a culture of change. And if one thing gets done in the nursery, and especially if it's a doctor that's doing it, then everyone else is going to follow your lead and do their stuff in the nursery. And I think once we realized what we were really talking about, things started to fall more into place. So, you can argue till you're blue in the face that the lighting is perfectly okay, but if the lighting isn't truly the issue, you're kind of wasting your time. And you really have to think about what the real issue is and acknowledge also that they're afraid of changing and that people don't want to do these things in the room because they don't want to talk to the parents or, they really don't think it's worth it. They don't see the validity in what you're trying to persuade them to do. And then I think a lot of the time we really have to swallow our pride, and this is why I talk about, don't be too pushy, because it's really difficult. You've been singing this song for 10 years and suddenly someone else gets it, and suddenly it's very, very tempting to say, I told you so. But it's much more productive if we can try and be really creative and find face-saving options, because these people are going to have to start doing it a different way, and they don't need their noses rubbed in it when they start to do that. And I think part of what will help us as advocates to do this is to look at the stages of change as they applied to our situation. So the stages of change is a established concept, and I'm just applying them to this particular 10-step situation. So first of all, in any process of change, you start off with an equilibrium, okay? So that's where we're at right now, and we're happy. We've been doing this practice. Nobody died, hopefully. Things are okay. People go home. People come back to the hospital. It's all okay, and everything's stable, and we know what we're doing every day when we go to work, and we're happy. And then the next stage of change is denial, and that's when they ignore you as the person who's doing the change. So, well, someone here is telling me I should be doing it differently, but I've always done it this way, so I'm not going to take any notice. I don't really think that that's going to change. Nothing's going to happen. And then people actually start to push change, and then you start to experience anger from the people. And they say, oh, my goodness, they're not going away. Like, they're actually here, and they're actually going to try and make me do this, and then people start to get very angry, and you will definitely encounter that anger and resistance from people who just do not want to do it, and you'll encounter it at all levels. And then the next stage of change is bargaining. And this is actually, in my opinion, the most dangerous stage, because they feel like they, being the resistors, feel like they're being very kind of fair because they are going to offer you a bargain. So if you're trying to establish rooming in, and right now all your babies are staying in the nursery for 4 hours, they will come up with what looks to other people to be a very rational, and fair, balanced thing. Okay, well, instead of putting them in the nursery for 4 hours, let's put them in the nursery for 3 hours. Or I had another hospital where they said, okay, so all breastfeeding babies, they're only going to get 1 bottle a day instead of us giving a 6-pack to the mom. So, that part of it's very difficult because you don't want to look like you're uncompromising, but there's absolutely no point in accepting a half measure that you're then going to have to change again. Because if you say, okay, let's do 3 hours in the nursery instead of 4, they feel like they've given you their best option, and then you're going to come back to them and say, actually, we don't want them in nursery at all. So you have to be really, really careful about, what you change. And rather than, compromise, I would advise, just change one thing, not 6 things. Just change one thing. So if you're going to do, remove the pacifiers, you remove the pacifiers and you lock them in the Pyxis. You don't say, okay, well, we'll just take them away from moms, unless they ask for them or unless it's a night. You want to be clear, okay, all the pacifiers are going to be in the Pyxis, and it's only, with documented medical requests and need that a mom gets them, or whatever. But make sure that whatever change you make is what you want to be at the end. Don't make a compromise, because that's really dangerous. You'll end up having to renegotiate everything and look bad. So when you do start to make these changes, the next stage is chaos. No one knows what's going on because things have changed, and this is also somewhat dangerous in that this is the time you have to be very careful to make sure things are safe. so if you start doing skin-to-skin on the chest, you need to make sure before you do that that your nursing staff is trained to watch the baby on the chest instead of watching the baby in the warmer, which is not very different, but it's still a shift, and you do not want some baby collapse on the skin-to-skin. First of all, you don't want to harm a baby, and secondly, even if that collapse would have happened anywhere else, if the baby's in skin-to-skin, baby-friendly will be blamed, and you will be back to square one. So you want to make sure that as you do these changes, and as you know, there's always a risk when you change anything because people are not used to doing it that way. So you want to be very careful to watch for the safety. And then you start to move through the chaos. And I actually like to quote Trish McEnroe from Baby Friendly USA, who told me once, you know, it's like you set yourself, you're going to tidy out your closet, and you say, this closet's such a mess. And you take everything out of the closet, and then you look behind you and you think, oh my goodness, like, what did I do? I should just have left it alone. It's miles worse now to have to deal with than it was all shoved in there. And you do get to that point with Baby Friendly, but then eventually things start to repair themselves and you put things back neatly, and eventually you have a well-organized closet. And once you start to move beyond the chaos in this process, you kind of do that. You'll have some gloom and doom from the staff because they're going to think, oh, you know, we're done for, we've lost, this is never going to be nice, we're going to hate working here. And then they start to get resigned to the new way, and then actually is when they might start to listen to you. So you may feel like, wait a minute, I told you that, you know, 6 months ago, but it isn't until they get through all these different processes that they get to the point of being actually able to listen to what you say, and agree, you know, and sort of actually hear what you're saying. So at that point, I think, is when you should sort of start to teach again from the beginning what this is all about, because then they're suddenly open to hearing it. And then they come to a point of readiness where they can try this thing, and then they actually re-emerge like a chrysalis. And this is the face-saving bit, but, you know, we all believe that our doctors and nurses are good people. That's why they went into this in the first place. And they do recognize in themselves, as they start to do a more family-friendly way of practice, that this actually is a better way of doing it, and they're doing a better job. So you can get there. Some of the strategies that help them along the way to give, you know, incentives, certainly offer competencies and CMEs for the clients, so that you're actually giving them something that they can measure that's of value to them. Very simple strategies to offer food at the meetings and the task forces, feed people, it always makes them happy. The gold star approach, you know, you would think that in our grown-up world we don't value gold stars as much as we did in kindergarten, but you would be wrong. If you look at any incentive program around the country on all advertising, everybody likes to get a gold star. So you can find ways to honor people for the work that they've done, and you know, make it visible to others when they complete training. And swallow your pride and forget history. And when people do get to that point of doing something differently, just be really congratulatory and helpful and supportive for them. And if these things fail, you have to be able or ready to bring in some of your big guns. I mean, you're not going to be able to get baby friendly unless you have some of the big guns supporting you at a higher level. And at some point, you know, leadership really matters, and that will make a difference. Some of the incentives that they've used, this is one of the Indian hospitals I worked with, and they had beads. One of the Indian hospitals I worked with actually had the elders make these beads, but these are beads that are belly balls, and those, when the nurses completed their 15-hour training, each of them got one of these beads to pin onto the lapel, which was a useful teaching tool for the parents as well. And also it showed everybody else, once they got them on there, that they completed their training. You know, don't forget your counseling skills. A lot of us, especially like people who are in nursing and lactation, you know, a lot of our training is in counseling and supportiveness, so don't forget that when you're dealing with other staff members as well. One thing I liked, some of the Swedish midwives I've had the pleasure to spend time with taught me when they were doing the nurse training, they had a stone on the table, and they passed the stone around to each nurse as they were doing the training. And as the nurse held this stone, she told her own personal breastfeeding story and what that meant to her. And then as she put the stone down, she said, and that with, you know, putting this stone down, I'm letting go of that. Whether it was good or bad, it wasn't going to interfere with her professional behavior going forward. And venting sessions can also happen, you know, if you get everyone, ideally not with a supervisor, but we've done these when we go to hospitals to do site visits. We just meet in a room with many nurses and they can express the concerns and worries that they have. And one of the good things about these sessions that we found is, you know, sometimes the worries are so extreme that other nurses within the same room will say, well, come on, it's not that bad. You know, one hospital we were at, one of the nurses said, well, we shouldn't give moms pumps in the NICU because they can't afford them when they go home. And someone else in the session said, well, wait a minute, you know, WIC pays for a pump. So, and so you'll find that even if you're theoretically everyone's venting, they're all venting about different things, and often some of the solutions can emerge right there in that session. It does get sometimes to feel like, you know, you're doing the same thing. I've said this, and I can assure you this happens for me. I go to so many hospitals, and I hear the exact same thing over and over again. You know, but, you know, have fun with it. Think to yourself, oh, here we go again. You know, I already dealt with Dr. So-and-so, and now Dr. somebody else is saying the same thing to me. But, you know that you've dealt with it somewhere else, so that should give you confidence. Leaders are really important, and it doesn't have to be your CEO, but leadership in general is really important, and it's really important to find those people within your system who will follow you and cling to your vision and support you when it needs to be done. And because there are many people, I can assure you, just going around Mississippi, that we are seeing many, many people last week who really want to do this, and they're not outside people, they're people in the hospitals who've always had this dream but have really not had a place to turn to. And, you know, a program like this and leadership within the hospitals gives those people a solid thing to cling on to. So really make sure that you cultivate leadership and make sure that you cultivate the support of the people who will really want to help you push this forward and give them things to do. You want to be organized, have a task force, lead the meetings well. There's a lot of work to be done, and you need to be able to share it and delegate it. You know, one person, one lactation consultant cannot do all this. We have to be able to share the load with other people. And sometimes you have to just put your foot down. I mean, sometimes, like with the bargaining, no, we can't say 2 hours in the nursery, we're going to rooming in. So you need to be able to do that too. But not micromanage, and make sure that people have developed confidence in their own ability. And keep a sense of humor, because I would never be in this anymore if it weren't for humor. You just have to keep a sense of humor. If you're just completely earnest all the time, you're going to burn yourself out. So, you know, allow yourself time to laugh at things. We had some debate yesterday on the call-in about how to form a task force, and we're going to put some work out there for you on that, because a few places, especially those at the beginning, have been asking us about creating task forces. But it's really, really helpful. This is the task force we had at my hospital, gosh, nearly 20 years ago now, when we became baby-friendly. We all looked terribly young in that picture. But that was our task force. It really helps you to have a bigger group backing up. And then, you know, if one person in the task force isn't very good or isn't very effective, you've got a bigger group there that can pressure them, even if it's subtly. You know, there's an expectation when they come to that meeting that they'll be able to report out on what they've done. And you need wide representation, so you need people who are from OB and nursing and prenatal and every different group, pediatrics and NICU, and from your community partners and WIC, because you really need a broad group of people, not one group that's trying to press everyone else into it. And it's really great to have a mom on there, and certainly peer counselors and people that can talk from the community's perspective, which is one thing we push for CHAMPS. If you do not have a task force, you will not get through this in the end. You can only get so far without the cross-disciplinary buy-in. And people who just sort of try and go it alone will never. It's very, very difficult. You need to have a group that's really involved and working together. So offer the staff something, as I say, you know, invest in the people who will help you and become your spokespeople, empower staff in all areas and all disciplines. And parents, staff are parents too. I mean, one of the best coups we ever made in our hospital was to do the lactation counseling for our public relations lady. She has never forgotten myself and Bobby Phillip when she had her first baby and couldn't breastfeed, and she was calling Oz. And, you know, we didn't do it for this reason, but my goodness, that's paid off, because here we are 15 years later and she still calls us. Whenever any stories come up about breastfeeding, she always thinks of us and links into us because we helped her personally. So, you know, they also are young women pumping, many of them. So this is a nice hospital poster for the staff. for all people about support, but you'll see on the left side of that poster, it's about staff support. So you also want to be sure that you support them with pumping facilities in the hospital. You know, you're not going to be able to create advocates for patients and breastfeeding if you don't support your own staff in breastfeeding. And especially in a hospital, a breast pump is not a very difficult thing to acquire and locate and put in a place where staff can use it. So it's a really good idea to get your employee program up and running and make sure that those people are supported in your own hospital. That will give you a lot of buy-in. There's nothing worse when you do an assessment, and I've done this, assessing and talking to nurses, and they say, well, we're doing all this stuff for the patients, but when I had my baby, there was nowhere for me to pump. You do not want that kind of mentality, so you really want to look at what your staff need. And then get the staff out there presenting in different conferences and, you know, showing their strengths and getting some of the credit, because they do deserve the credit because they're out there doing the work. And you need to really make sure that when there's representation locally, if it's an A1 conference or a pediatric conference or a public health conference, that you get your hospitals and your staff up there in central. There's many opportunities. Proactive help can make to buy the doctors in. This was a great letter. This was Cherokee Nation Hospital in Oklahoma, and they were having, as many of you do, major problems with their physicians. And the CEO of the hospital wrote this letter and hand-delivered it to every single doctor that was in the OB and pediatric unit, asking them, you know, inviting them one-on-one to come to this presentation that was outlined in here. And it was hand-delivered by the CEO, and it was on this beautiful gold-embossed invitation. It looked like they were being invited to a wedding. So that kind of personal touch and, you know, real sort of subtle, one is subtle, but that kind of approach, the one-on-one approach, can really help to bring people in. And this is the same hospital, actually, where also at the hospital all the doctors' coats have been purchased for them with these emblems on the sleeve. So whether or not the clinicians really supported breastfeeding, they went around looking like they supported breastfeeding because they had this mother-baby embossed on the sleeve of the white coat. Administrators like thinking about time and money and priorities. You can make it easy for them, help them to think that they thought of the solution. And if you're coming in with a problem, you need to bring a solution. That's one thing we learn as we go through this. It's no good just complaining and bringing problems. Bring them solutions, because your administrators, like our public relations lady, for example, can be huge advocates. And I'm thinking all different areas of the hospital. In terms of your sort of day-to-day nursing staff, your various shifts, it can help to think of them as three groups. Actually, I'll move on. So you've got your people on the left who are all really, really happy and just raring to go and have been waiting for this to happen. And then your biggest group is pretty well in the middle because, you know, everybody has their thing that they're really excited about, and maybe this group's really excited about something completely different. So breastfeeding's not their big thing, but, you know, they're certainly willing to listen. And then you kind of have your angry little group in one corner who really want to resist it, you know, and what your goal is to move this middle group up into the big happy group. And then your sort of grumpy people get either just completely left behind and isolated, and then either they sort of whiz over and join you, or they jump ship. But, you know, your goal is to shift the sort of major concept of everything towards breastfeeding, and then bring on the naysayers at the last minute. You know, and as I say, I have faith that all our clinicians are good people, and that's why they went into that. And remember that your nursing are told to follow certain rules, and they may have been following these rules and policies for years. And so, you know, they've been doing the right thing, and it's really annoying when things change. So don't change everything at once, and listen to their real concerns. Maybe they're not so worried about the breastfeeding. Maybe it's the documentation they're worried about. So really try to nail down exactly what they are. And I like this thing. I got this from our NICHQ session, where the role of the RN has really changed over the years, and you may still, you know, be employing nurses who fit into the category of nursing that way long ago the nurse was the boss. I mean, the sister on the ward, the person who was in charge, the person that no one would ever contradict, and she kind of ruled the place with a rod of iron. And then it's kind of moved to maybe 10, 15 years ago. It was more like the nurse was the hotel concierge. I mean, she was supposed to provide everything. She was almost like a servant to the patients. And I think now, perhaps, we can say that the nurse's role is more like of a personal trainer. We're not going to do every diaper change. We're going to show them on how to change the diaper. We're not going to feed every baby in the nursery. We're going to teach the mom how to breastfeed. And I think that if you think of it a little bit like that and think that some of our nurses may still be stuck in some of the former roles, that can also help us. And then the doctors, doctors are good people too, and they can be your best allies. And once you get them bought in, and those few of them who are already bought in are really going to be invaluable in leadership. And we know that doctors listen to other physicians, so it's a good idea to get other physicians in to speak to them. I might add that even if we are physicians, I'm not a physician, but even if you have a physician who's able to do this, it's very hard to be a prophet in your own land. So you might want to swap your positions around. So maybe all the Champs Louisiana hospitals can send their physicians to talk to the Mississippi hospitals and vice versa, because people tend to listen better to someone who comes in from the outside. But that only means to be a bit clever and switch them around, because they're all saying the same thing. We've had some wonderful experiences with doctors. This was a conference that Dr. Winter and I did in New Jersey. And we had a lovely obstetrician who stood up in the audience basically and said, I'm the problem, what can I do to change? I am the problem. And I've heard that in more than one situation. But, a couple of things to remember about your physicians. They're advocates for patients, and they're probably advocating for them on all sorts of issues like third-party payers, other hospital practices. So your goal is to help them be baby-friendly advocates. And remember that at the bottom line, they want all the moms and babies to bond well and be happy together. They want the best outcome for all the babies, and they want happy mothers, not angry mothers. And they are going to be the ones talking to you about rooming in and exhaustion and everything. But, a lot of that has to do with the prenatal preparation and the way that this is approached. And a lot of them have these misconceptions that there will be no formula available in the hospital at all, and that the babies will be screaming and starving. There'll be no pain management, no pacifiers, and of course there will be pacifiers to be used in NICU and to be used in pain management. So it's very important to make sure that they get clear information about these very pragmatic things that they often think are not going to be there for them anymore. And I think it's important to get in the door and explain the baby-friendly culture, which is that it's not just breastfeeding. It's an educational thing, and it'll help the mothers rather than making the moms feel angry or guilty. If we give the right information, more mothers will choose to breastfeed, and the Baby-Friendly Health Initiative will help those mothers by making breastfeeding easier and helping them to succeed and increasing their confidence. So they're not going to get the mom who comes back crying at the 2-week visit saying, her nipples are in shreds, because we've taught more people to handle the education better. And, I think some of those who really cannot see beyond this breastfeeding, forcing breastfeeding, I think it's really important to emphasize to them that it doesn't just apply to breastfeeding women. So skin to skin is for all mothers. Rooming in is for all mothers and babies. Feeding on cue versus overfeeding is for all of them. And safe formula preparation and education about that in the hospital is an important part of this initiative. And I think, if you're not able to convince them anything about breastfeeding, I think going for the maternal child care optimal practices is another way to go. I realize, guys, I'm giving you like a massive amount of information, and I'm just hoping that you'll take from this the few things that, will help you in your hospital today or in your community today, rather than saying you think you're going to have to deal with all of this. And hopefully this work with, patients that we're doing increased education in the hospital will prevent the patient from coming into the doctor's office saying, I wanted to breastfeed and it didn't happen. People do complain, doctors do complain. They had a patient in tears in the office, or the exclusively breastfed baby's coming back and has been starved because no one really taught mom about feeding cues. And you can explain that there's a major amount of training involved in the Baby-Friendly Initiative in the hospital, and that all the nurses are going to be better trained than they were to help all of the different mothers in whichever situation. Because it's a mandate for Baby-Friendly that you must train the staff. So explain there's 15 hours of training, there's an evidence base to it, and then share the policies and the revisions with your physicians so they know what the policies are and what has changed. Because it's interesting, when I go around and do assessments and I ask physicians, is there a breastfeeding or an infant feeding policy at this hospital, they often interpret that to mean, yes, everyone has to breastfeed. And they say, oh, yes, we have a policy, everyone has to breastfeed, which is not at all what an infant feeding policy is. An infant feeding policy is a document in the hospital that spells out how you work with all these different cases and how to follow a procedure. But often they will just jump to the conclusion that the policy is you must breastfeed, which is very much a misconception. And then, we're big on the community in CHAMPS, and we know that all moms want the best for the baby and that human milk is best, and that we can convince them by not undermining them and empower them so that they come in asking for this if we talk to them at a community level in the prenatal settings and present it to them, to the prenatal officers. This is being hospital practice, therefore your patients need to know this information because this is what's going to happen when they get to the hospital. So just to sort of go back to those particular pediatricians and their lighting issues, a year or so later, I was at a breastfeeding conference in that state, which it happened to be the state of Oklahoma. And that hospital was just doing great. And I won't go into detail because you'll be able to identify which hospital it was, but they were doing absolutely great. And two of the pediatricians were at this conference. And they were like joining in calls and everything. And one of them was a pediatrician that when I was in the hospital, I'm not exaggerating, the guy tried to leave the room when I asked him to do hand expression, and he was very difficult to actually get to nail. And I saw him in this conference, and I sort of looked, we kind of glanced at each other, and then there's a big smile, and I said, okay, tell me what happened, because you're doing the exams in the rooms, and I do remember how opposed you were to it. And the guy was very honest, and he said that first exam in the nursery was like a religious rite. He said, and we were really afraid to let go of doing that first exam in the nursery. Something terrible would happen if we gave up with that. And I think that was just, a really moment of honesty, and we all felt that, we'd come full circle, and that now these hospitals, in fact, on that invitation you saw, one of the doctors named on that invitation for the other hospital in Oklahoma was coming from the resistant hospital before and was now going out as an advocate. So I'm not going to go into this in depth because I think PDSAs is a whole different thing, but I will just give you this one picture of a PDSA, which is, when we talk about change and how to do change, this QI measure called PDSA, or Plan, Do, Study, Act, is basically a way to logically do this change one time, choose one baby, do it once, and see what happens without implementing sweeping change and learn from your experiences. So, and as you do more and more of them, you will see that you can apply them and then you can start to roll them out and do more and more of the practice and less of just PDSAs. But some ideas for doing a PDSA would be, for example, just to put one baby skin-to-skin post-cesarean, to do one pediatric exam or one bath or one hearing test in the mother's room, to track one baby's movements in and out of the room all day when you're trying to figure out rooming in. And I'm just going to use this one example, which was created by a good friend of mine at the Indian Health Service, Jenna Meyer, who was in one of the Oklahoma hospitals that we worked with. And they decided that they were going to work towards rooming in just by starting by weighing the baby in the room. So they weren't doing rooming in, and most of the things were being done in the nursery. So they said, okay, one thing we can change, first is we'll do the weights in the room. So they decided that they would keep the babies and mothers together, but the first step would be to do the weights. So Plan, Do, Study, Act. So at the planning point, they had a goal, which was to do the weights in the room. And then the questions that they were looking at with the plan was, would the scale go into the room without disrupting everyone's routine? And would the moms accept having the baby weighed in the room around midnight, or would it be waking them up and upsetting them, and would they need to change the time? Because usually the weights were done at midnight. So that was the plan. That's what they were going to do, start weighing the babies in the room that night and see what happened. And so they got a portable scale. They didn't have a portable scale. It was interesting. They had a scale that was really big and wouldn't wheel around, so they actually switched it with a different unit in the hospital so that they got a light portable scale that would fit through the doorway. And they predicted when they were planning this that it wouldn't be very disruptive. That was their hope and prediction. And then they set up the rest of the plan, so who was going to do it. So it was going to be the night shift nurse that was going to do it, and she was going to weigh all the babies in the mother's room that one night, just on that one night. And then it was going to be on a night when Jenna would be supervising so that she could be there to oversee it and analyze the results. And the way that they were going to do it was to simply wheel the scale from room to room. So that's what they did. Renee weighed all the babies in their mother's rooms that one night, and they found that mothers were awake anyway because that was the same time that the mothers got their last assessment of the day. So that was good. They didn't have a problem with that. They also found that the time that was spent in the room was no longer than it was to weigh the baby in the nursery. They found that the nurse was not very comfortable when she did the first one in the room, but as she did 2 or 3 that night, she felt more comfortable sort of talking to the patients and being on good terms with the patients. They did find that the scale was bulky, so I guess they changed the scale after they did the PDSA, not before. But the scale was really too big to wheel around, so they ended up actually switching it after this with a smaller one. And then there were some things that were missing when they pushed the cart around that they needed to replace and put on again. So those are the things that they found. So they found a smaller, more portable scale in the pediatric clinic and switched them. They added things that had been missing to the cart, which was the gauze, the clamp remover, and the alcohol. And then they went ahead and redid the PDSA with the changes. And then they started a new cycle with a new scale. And now, as they progressed through that and once it ironed out all the kinks, they now had moved to, of course, now they're baby-friendly, but at that point they moved towards weighing all the infants in the room with the mom at midnight. So that's, you can see how this one simple example of a PDSA. You don't have to get buy-in and consensus every single time. You want to collect useful data and information and test them over a wide range of conditions. So if you were to, say, do the hearing test in the room, you would start out when it was really a quiet time. But then as the people get more familiar with it, you know, you may have to do them when there's a visitor in the room, and you have to figure out how that goes. So you want to do them in a range of different conditions. And you really can't fail with a PDSA because it's always a test. So as long as you learn from them, they're successful. And the only unsuccessful PDSA is the one that doesn't get done. So I'll end this presentation and open it up for questions, but with a somewhat of a challenge to you. I would like those of you